So for those of you who aren't already aware, at the end of March, the FDA issued a safety communication regarding injectable iodinated contrast agents, so what we know as IsoVu, for example. And the content of that communication or warning on contrast media specified a risk of hypothyroidism related to injected iodinated contrast, that patients at unique risk were newborns, prematures, and cardiac patients. And what we're here to discuss is that the recommendations included in that communication by FDA were that parents and caregivers should seek information on the risk of clinical hypothyroidism, subclinical hypothyroidism that might be associated with contrast injection, that health professionals like us should monitor exposed patients from birth to age 3 years, and that all parties, parents, families, we as providers, should report adverse events or side effects through the FDA MedWatch site. So just if in case anyone hasn't seen it yet, it's available on the FDA website, and that's sort of the starting point for the next presentations.
All right, guys, so everyone knows Dr. Sathanandam, head of the cath lab at Bonheur Children's Hospital, is going to kick off our first talk, and we're going to try to move along pretty quickly so that we can get to the open discussion at the end. Thank you.
All right. Thanks, Audrey. Thanks, Arash and Henri. Okay, I hope Henri and Vasum can hear us and see us. So I said my interest has got in this topic is because about 25% of my practice is premature babies or neonates, so it affects a lot of my patients. So I talked to Audrey, and then we started talking about the session. Anyways, I'm just going to give a little background of why hypothyroidism happens with iodine exposure. I'm going to do this by little cartoons. So there are two thyroid hormones, T3 and T4. T3 is the active form and T4 is a prohormone. They both have either 3 or 4 molecules of iodine in it. So the thyroid gland has these thyroid follicular cells or the thyrocytes, and inside these follicular cells or follicles, there's this colloid, which is basically thyroglobulin. On the basolateral membrane, there is a symporter called the sodium iodide symporter, which brings the iodine into the cell, and then it's secreted into the colloid, where there's an enzyme called a thyroid peroxidase, which oxidizes the iodide into iodine, and then it bounds to thyroglobulin. So it either has one molecule bound to form monoiodothyronine or 2 molecules bound to form diiodothyronine, and then they conjugate to form either T3 or T4. So it depends on the number of iodine molecules there are, so that forms either T3 or T4. So once the hormone is made, it gets engulfed back into the thyroid follicular cells, and the thyroglobulin gets lysed, and the T3 and T4 is now released into the vascular system. Now, the regulation of the thyroid hormone is through this axis called the hypothalamus, anterior pituitary, and the thymus gland. All this we studied in medical school. The hypothalamus makes this TRH hormone, which stimulates anterior pituitary, which stimulates the thyroid gland with a thyroid stimulating hormone, which makes the thyroid hormones being synthesized. But they also have a negative feedback inhibition of the thyroid of the TRH and TSH. So this is negative. Some stimulus such as cold actually has a positive influence in thyroid hormone synthesis, and negative influence are stress and corticosteroids. Now, iodine is a halogen. It's one of the heaviest halogens. So on the periodic table, it's got an atomic number of 53. So it's got 53 protons and 53 electrons on it. So it's a pretty heavy halogen. Now, the recommended daily intake for an adult, the iodine intake for a euthyroid state is 150 micrograms per day. For a child between ages 1 and 8, the recommended intake is 90 micrograms per day. What happens is when we do angiography using iodine-based contrast, the serum level of iodine with 100 ml of contrast can be about 100 times more than what is recommended in an adult. So it causes severe iodine excess in the blood. We found that even if you use skin prep such as betadine, just a groin skin prep can increase your iodine level in the blood. And if you use iodine for like for open wounds and stuff like that, then that level is even higher. What I also found out that many of our sheets actually have potassium potassium iodide bound to our sheets, and that can also increase your serum iodine level, but we don't know, no studies have been done to what level. Now, what happens when the iodine level goes up? When we inject dye, the iodine level goes up. So this is just a basic. So here's your thyrocyte. On the basolateral aspect, you have the sodium iodine symporter, which brings iodine into the cell, and the thyroid peroxidase makes T3 and T4. Now, there's an effect called the Wolff-Chekhov effect when the iodine is excessive in the blood. So when the iodine is excessive, the sodium iodine symporter is upregulated, so more iodine gets into the cell, but it negatively affects the thyroid peroxidase enzyme. So there's actually a decrease in T3 and T4. So you get hypothyroidism with excessive serum iodine till there's this phenomenon called the escape from the Wolff-Chekhov effect that comes about by, and I'm going to go into that a bit. So what happens in the Wolff-Chekhov effect is the sodium iodine symporter is upregulated, so that receptor binds to more iodine, brings iodine more into the cell for about 10 days. And after 10 days, the symporter is downregulated, so it's a smaller symporter, so no longer brings more iodine into the cell, and you get to a euthyroid state. So that effect lasts about 10 days. So when you give iodinated contrast, the serum iodine goes up, and you have this Wolff-Chekhov effect that lasts for about 10 days, leading to hypothyroidism. And then after 10 days, there's escape mechanism, and you go to a euthyroid state. The problem in neonates is that they are at very high risk of not to escape from the Wolff-Chekhov effect. So the Wolff-Chekhov effect lasts longer, leading to prolonged hypothyroidism. And neonates with hypothyroidism can lead to adverse neurodevelopmental outcome. And I think that's why there is this safety communication from the FDA. And with that, I'm going to finish with this one picture. This is a picture that's in my cath lab. So this is a baby orangutan in our zoo that they call for failure to thrive. So 1-month-old baby orangutan, and they found to have a large PDA. So they asked us if we can close the PDA, which we ended up closing the PDA, but the failure to thrive never got better. It turned out that the orangutan also had hypothyroidism. They were so focused on the PDA causing the failure to thrive that they forgot about the hypothyroidism. But the hypothyroidism was diagnosed even before the PDA was closed, not after the PDA was closed. So we treated the orangutan with thyroid hormone, and the failure to thrive got better. So the zoo presented us with a picture of the orangutan with a thank you note. So it's in our cath lab, and I just wanted to finish with that. Thank you very much.
All right. Hi, everyone. My name is Arash Salavitabar from Nationwide Children's Hospital. I'm going to be doing a whirlwind review of the literature, really focusing in on the papers that were referenced in the FDA statement. No disclosures. So back in 2015, the FDA put out this drug safety communication, basically stating that rare cases of thyroid dysfunction do exist following contrast media in infants, usually being temporary and resolving without treatment. One of the several actions that were taken as part of that communication were to require manufacturers to conduct a study to investigate this, and 3 studies were referenced at that point. They followed this up, fast forwarding to 2022, with a statement that we're all aware of and talking about today, that there's compelling evidence of this up to 3 years of age following contrast exposure, and that a study by the manufacturers was no longer needed, and referenced 11 studies in that communication. Those 11 studies were published between 1987 and 2020. 7 out of the 11 of those studies, importantly for us, included patients with congenital heart disease, some exclusively so, and 6 out of the 11 included patients who received cardiac catheterizations. And I'm going to talk a little bit about the heterogeneity of those study designs. The study populations across those 11 studies were mainly infants, some older children, and most including neonates, anywhere from preterm, very low birth weight, to full term. Exposure types range from CTAs to cardiac caths to central line positioning, confirmation, as well as IV contrast for urography. Many different contrast media were used, obviously a lot of overlap between them. And only 3 studies explicitly excluded iodine-containing topical disinfectant, with 2 including the topical disinfectant as an exposure type in their analyses. Volume of contrast per exposure varied greatly. Patients who had medications that affected thyroid function were excluded in 3 studies. And they did a pretty good job of either excluding patients who had a prior diagnosis of hypothyroidism, or at least getting baseline TFTs in those cases. So the studies that reported an incidence within their study populations reported anywhere from 0% to 23.8%. Time to diagnosis was a median ranging from 8.5 to 117 days, and then an overall range that was pretty extreme from 1 day to 25 months, obviously the less common along those extreme ranges. 3 studies explicitly looked at chronic versus transient hypothyroidism versus following contrast exposure. The vast majority of those patients had transient. And 6 studies looked at the need for treatment, and 49 patients out of a total of 179 in those studies received treatment, and of note, 20 of those 49 patients were from a single study. So looking at, for an important factor for us, contrast dose and contrast load were not significant predictors in 2 studies, but in another 2 studies, they did look at hypothyroidism following cath versus following CT. And these studies used that as a surrogate for the amount of contrast that was being received, assuming that cath procedures resulted in a higher contrast load. And they found that the higher rate was seen following caths in those patients. And then frequency of exposure was found to be associated in 2 studies, one showing that a median of 4 exposures versus 2 had a higher rate of hypothyroidism, and the other showing that greater than 3 procedures that included contrast as an exposure also had an odds ratio that was about 3.65. Age was associated in 3 studies, 1 to 3 months of age being the highest risk. Several studies included exclusively NICU patients, so it was really hard to really decipher whether those were higher risk than patients who did not have those risk factors, and then one study had no association. Gestational age and birth weight showed no significant predictors. And then, as you can all imagine, sicker patients had a higher rate, so patients who had ICU stays, worsening renal function, and were on thyroid disrupting medications were also found to be associated aside from other factors. 2 studies were actually negative in their association, so patients in one study were less than 30 weeks gestation with very low birth weight who received CVL confirmation with contrast, so very low volume. And then another study in full-term normal birth weight infants that received a much higher volume, similar to what we do in the cath lab for urography, and they did not have a higher rate as well. So what can we conclude from all this? Exposure to iodine does have some demonstrable but apparently transient and reversible effects in certain patient populations, of course, that we still have to decipher. Risk of hypothyroidism is clearly multifactorial, and clinical significance of all this is unclear until we study it better. And then obviously the implications are going to be unclear until we further investigate in larger cohorts. So thank you very much.
I'm Audrey Marshall. I work at Sick Kids in Toronto. I'm going to be talking mostly about the reaction response, sort of as it is today, and I'll start just by sharing SCAI's, your Congenital Council met, discussed this issue about a month and a half, 2 months ago. We did a very brief survey just of the people on the council, so there were about 21 people. And we just asked, do you agree with the statement that was in the FDA communication, which is that all infants and children under age 3 receiving injectable contrast should be screened for asymptomatic hypothyroidism. As you can imagine, 90% of respondents in that N of 21 said no. However, there was the expression of an alternate position, which is that yes, they should, or maybe they should. And another question that was asked, and I think this 10-question survey, was, do you feel there's sufficient clinical evidence to support the recommendation as worded as above? And as Arash shared with you, there really isn't very strong clinical evidence, if any. And so most people concurred that there wasn't sufficient evidence for the reader to agree that the recommendation was warranted. I'll let you know that we've been talking to providers and colleagues in other disciplines, including the American College of Radiology. There's a link here, which I'm happy to share. You can just find it on the ACR site. The American College of Radiology has posted a policy statement already that's quite strongly worded and very aligned with what I think most of the people in this room would say based on what we're sharing with you today. The Pediatric Endocrine Society has met. If you go to their website, they have a sort of placeholder statement, not a full policy statement yet, but an indication of their sentiment, which is very similar to that of the ACR. And there's currently being drafted, I think, and other people in the room may know more, a joint statement being collaborated on by the AAP, the ACR, the SPR, Pediatric Endocrine Society, and this group, SCAI. So that's in early stages, but there have been some assignments made as to collaborators on that work. I do think another very important action is to disseminate this information to our colleagues in critical care in particular, in our pediatric cardiology community and referring providers, and also the neonatologists that we work with relatively frequently. We need to engage our own community that involves the work at these kinds of society meetings, written materials that are being put together now. sort of leveraging formal networks, some of which are listed here, as well as informal networks, just sort of spreading the word, I think, and making people become aware of this issue and become educated about it. We do need to inform patients. I think it would definitely be in the best interest of our community to engage patient advocacy groups and begin to educate them on the topic as well. Monitoring the situation, I had spoken with Vasum about where the FDA intends to go from here, but I think staying in close touch with FDA about whether there are any steps on the horizon would be critically important. And I think engaging one seat at the table that's been empty is the manufacturers. They have a lot of other stuff going on right now with supply, which may make it difficult for them to hear our concerns, but that's sort of a missing piece of the puzzle, I think. Determining what additional information is necessary, we'll talk about whether this community wants to initiate some additional fact-finding or data collection, and then importantly, anticipating any unintended consequences. There will certainly be unintended consequences of pursuing this actively right now. We just as a group need to think through them pretty carefully. I think all the societies are agreed that we need to take this quite seriously, that there are patients who can be defined as high risk. They're the preterm population, those who are acutely ill and hospitalized, and those who are very young, less than 3 months of age, who might be screened, some of these higher risk infants. I've already listed some of what generally by consensus people have identified as risk factors. The question about dose and number of exposures I think is really an open question, and that's going to be something we need to work through. What are we talking about in terms of screening? The Pediatric Endocrine Society is recommending venipuncture, withdrawing of a TSH, and then follow up with a TSH and free T4 following meeting of a threshold value on the initial TSH screen. I mentioned yesterday in the session about maybe, again, taking advantage of some of the existing programs of high-risk patients like preterm PDA or pulmonary vein stenosis, kids who are going to have, or ductal stents who are going to have repeated contrast exposures at a very young age, and many of them are critically ill or in ICU settings. Where is this going to happen? This is a big implementation question. Many of these kids who we think are at highest risk are in the ICU at the time that they have their exposure or their contrast encounter. However, hopefully they're not all still in the ICU 2 to 3 weeks later when it's appropriate to become screening for their failure to escape Wolff-Chaikoff. So they may be in an inpatient setting, which makes it somewhat simpler. If they're in the ambulatory setting, this becomes a real implementation sort of nightmare for us or our whole community. When might they be screened? Shyam is already screening pre-procedurally. So I think one thing to talk about is, and this is one of those unintended consequences, we are going to find some, and so we need to know what the baseline is. Most of you know that there's a federal mandate to screen. Neonatal screening includes a paper blot test for thyroid function. But this is venipuncture, and I think in order to sort of compare apples to apples and be sure that we're looking at the same thing pre and post exposure, if we're going to monitor after, we certainly will have to do some baseline screening. Who's going to be responsible for the testing and the results is an open question. Where's the documentation going to live? Who's going to report? I mentioned, and the FDA mentions in their communication, their MedWatch site, which is where we should even now be reporting any adverse events that might be related to contrast administration. Who's going to orchestrate and administer therapy? At what level are we going to treat? And who's going to follow up? Because the end game here is not hypothyroidism or even contrast-related hypothyroidism. The end game is neurodevelopmental outcome, and I think Arash hopefully drove home the point that it's not most of what we know about neurodevelopmental outcome, about adverse neurodevelopmental outcomes in the setting of hypothyroidism, or the association has to do with congenital, untreated congenital hypothyroidism. It's totally unclear whether this transient hypothyroidism even has that adverse outcome. Given that the risk that our patients have on the basis of their congenital heart disease for adverse neurodevelopmental outcome, I think we have to be very careful about ascribing it to contrast exposure. This is from this morning. I just grabbed this off the FDA MedWatch site. So you can search that site for the contrast communication, and there's a drug safety page. And this is what the public has access to now in terms of the FDA's concern about contrast exposure. 2 last slides. Again, going back to that just very brief survey, although I think it's probably representative of our community at large. Question 4 in that survey was, does your institution use iodine-based skin prep solutions? And so there's topical exposure, maybe in 75% of our institutions. That's going to confound anything that we find in terms of cath lab contrast exposure. Question 8 in that same survey was, does your institution have a longitudinal database that records injectable iodinated contrast media given in different settings. That includes in radiology or DI, for CT, or in the cath lab or any of the other vehicles for contrast for iodine that have already been mentioned, and can that be interrogated on a per patient basis? And most centers said no. So even if we wanted to launch into a prospective look at this now, we don't have the machinery in place to collect reliable data. Finally, Jenny Zabla and I think Damien shared this survey that was done of some SCAI membership. The respondents, there were only about 50, but they asked a dozen questions or so about the same topic through the Doc Matters site or application or something. And I'll just point out that in response to the question, have you changed or are you planning to make any practice changes in your institution in response to this FDA statement? 37% said no, that they felt there was insufficient evidence, but the majority, actually 57%, said yes, either they're already doing it or they're going to conditionally change their practice. So I think that was a few questions I sort of came up with that might be worth discussing or might be part of our conversation here is how significantly could this change clinical practice? I think that survey suggests it's already changing practice in some sites. How likely are we to identify occult cases of hypothyroidism? How significantly could this actually change outcomes in kids with congenital heart disease? That's a big open question. What's it likely to cost? I think a cost-benefit analysis on this would likely indicate that it's probably unfavorable. Should we be drawing baseline TFTs on all CAF patients under age 3 is what we're here to discuss. Should we be tracking other potential exposures to iodine like catheters, like other studies? And should we be collecting data prospectively in a trial or a registry? There's some enthusiasm for that approach right now.
And again, let me just start out by saying thank you for the opportunity to speak with everybody today. Really appreciate the participatory support on this important issue. I'll turn off my camera just for bandwidth issues while I go through these this talk. But basically, I'd like to keep my remarks very brief and concise with a focus on providing some sufficient high-level context to support a clarifying conversation with the panel. Let me see if I can move my slide deck forward. There we go. So really, as all of you know, one of the primary aspects of FDA's responsibility for protecting public health is ensuring the safety of regulated products. And the Food and Drugs Act of 1906 was the first of more than 200 laws that constitute one of the world's most comprehensive and effective networks of public health and consumer protections. I won't note all 200, obviously, since we don't have time, but allow me to highlight 2 that authorize the FDA's foundational work in ensuring the safety and efficacy of drugs. In 1938, after a legally marketed toxic elixir killed about 107 people, including many children, the Federal Food, Drug, and Cosmetic Act was passed and completely overhauled the public health system. Among other provisions, the law provided the FDA with the authority to demand evidence of safety for new drugs. The thalidomide tragedy in Europe and the FDA's vigilance that prevented the drug's marketing in the US inspired the Kefauver-Harris amendments of 1962. These amendments strengthened the rules of drug safety and required manufacturers to prove their drug's effectiveness. These foundational laws and many other acts of Congress have supported the agency's development of multiple systems to monitor marketed products. When safety signals arise, they are evaluated from various perspectives to assess potential public health impact. And then, when appropriate, the agency develops and disseminates information to the public regarding important safety issues, including emerging drug safety information. An important drug safety issue is one that has the potential to alter the benefit-risk profile for a drug in such a way as to affect decisions about prescribing or taking the drug. Emerging drug safety information is information about an important drug safety issue that has not yet been fully analyzed and confirmed. Examples of important drug safety issues include serious adverse experiences identified after approval or in new use of a drug, or additional serious or more frequent adverse experiences in a patient subpopulation. Medication errors, such as those associated with dosing or delivery, are also monitored. But very simply put, what is the general intent of a drug safety communication? And drug safety communications are really intended to alert either the public and or clinicians to important safety information. Some DSCs are issued early in the review process as new information is being evaluated as an alert. For instance, the information that CDER released regarding this topic back in 2015 that's been alluded to. And other DSCs are issued when the data is more mature, leading to specific recommendations or providing updates based on new information, such as the updates provided on this topic by the FDA just a few weeks ago. As the FDA evaluates drug safety issues to determine whether regulatory action is warranted, the FDA may communicate further information to the public at appropriate points in the decision-making process. Now, one of the issues that comes up from the clinical community in many communities is the issue of whether there are any punitive medical legal aspects to the drug safety communications. Generally put, there are no punitive medical legal aspects to the drug safety communications. We only provide recommendations which can be applied as deemed appropriate by clinicians. So the next point is, what was the purpose of this specific DSC and what triggered this DSC? So for this 2022 drug safety communication, the intent was to update the community regarding our 2015 drug safety communication. Specifically, we wanted to help assure that the community was aware of three key aspects. First, the additional published data, which has already been alluded to, so I'll go through this quickly. But since 2015, the FDA first alerted the public about cases of underactive thyroid in infants receiving iodinated contrast agents or ICM injections. And new research studies evaluating this risk have been published in the medical literature since then. These studies are noted on our websites, and all the information that I'm presenting to you today is also on our websites. These published studies have assessed thyroid function in a range of about 10 to a little over 2,000 children from birth through 3 years of age who were exposed to ICM injections. Causal attribution of hypothyroidism to ICM injections is confounded by a few issues in a number of cases, such as those with concomitant use of other medications. In most cases of decreased thyroid hormone levels were temporary and did not require treatment. The reported rate ranged in our assessment from around 1% to about 15% of the populations studied, and tended to be higher in newborns, particularly those who were preterm. Now, patients with cardiac conditions were at greatest risk, possibly associated with the fact that they often require higher doses of contrast during invasive cardiac procedures, and the time from ICM exposure to diagnosis ranged between 8.5 and 138 days, with most occurring within 3 weeks in some of the publications. In 2015, we required the manufacturers of ICM products to conduct a study to investigate the safety issue further. However, CDER, our Center for Drug Evaluation Research, has concluded based on review of the published studies that there is compelling evidence for a significant risk of underactive thyroid or a temporary decrease in thyroid hormone levels in newborns and children through 3 years of age after exposure to ICM. Therefore, the study by the manufacturers was no longer deemed necessary, especially considering a safety labeling change was proposed by the manufacturers. This leads to the second point of which we wanted to help assure awareness, which is the approval of that safety labeling change and the warning to prescribing information for the entire class of ICM injections. As you know, the warning describes the risk of underactive thyroid or a temporary decrease in thyroid hormone levels. And then third aspect that we wanted to clarify awareness on is the suggestions for monitoring of the potential hypothyroidism. So the fundamental suggestion here for clinicians is to be cognizant of the potential for hypothyroidism and consider testing when deemed appropriate. Specifically, as has already been noted, consider evaluating thyroid function within 3 weeks of exposure to ICM injections, especially in very low birth weight and term or preterm neonates and children with certain underlying conditions, such as cardiac conditions requiring care in an intensive care setting. If thyroid dysfunction is detected, consider treating and monitoring thyroid function as clinically needed to mitigate potential cognitive or other developmental delays or disabilities. The FDA also encourages education of families and patients on this topic when appropriate. I'll reiterate here that the FDA provides clinical recommendations as general guides to help clinicians clarify the right management for the people under their care. These recommendations can be applied as deemed appropriate by the clinicians. And finally, what type of follow-up should be anticipated on this topic? So CDER welcomes additional input from all interested stakeholders and is available for listening sessions. Although there are no specific research initiatives currently planned by CDER on this topic, we recognize that additional data may lead to updated recommendations. CDER is willing to review and consider research findings from stakeholders, including academia and industry. To help FDA continue to track safety issues, and just as has been already presented, we encourage reporting side effects from ICM or other medicines to the FDA MedWatch program. Thank you, Audrey, for highlighting that as well. So let me close by saying that the FDA appreciates the collaborative engagement of organizations such as SCAI to help educate the clinical community and disseminate important safety information. The agency will continue to monitor this important issue as part of our ongoing dedicated efforts to ensure safe care for children. And I went through this quickly, but thank you very much.
Thanks. We're going to open it up for discussion in the time in the 3 minutes we have left. Really quickly, Vasum, while we have you, can I ask, you reminded me of my comment about manufacturing being, the manufacturers being sort of a missing seat at the table, and that MedWatch site is, one of my understandings is that the drug safety communication is explaining in some ways or communicating a change in the labeling. And I guess I would ask, was this kind of communication to the community, was the relabeling required for continued availability of the contrast for the purposes we use it?
No, a very good question, Audrey. I'll simply say that as anytime a safety concern like this is being evaluated and we are trying to consider what are the potential avenues and pathways we have to be able to better understand the scientific evidence that supports or brings up concern around these issues, we try to figure out, well, based off the information we have, what's the best approach and path we can take? And if there is a need to obviously alert the broader community, in this situation, the balance of the additional published data that manufacturers provided to us and the recommendation from the sponsors and manufacturers to provide that new safety labeling change, those two in combination was what led to a decision to deem the additional collection of data for an overall industry study less necessary, since that would be a challenging time commitment and process to complete, and not only for the industry, but also perhaps a challenge for many of the patients. So all of that being considered, this is why we've gone out with the communication in the way that we have. I hope that answers your question.
Yeah, I think so. We'll open it up for the audience members.
Vasum, it's Damien Kenny here. Unfortunately, or fortunately, I don't work in the US anymore. So I suppose the concept of a communication, and I know as the FDA, your regulatory body, would presuppose that you might reach out to some of the organizations, including SCAI and maybe PIC Society, before issuing something like this. Was there any consideration given to that? Because it was a bit of a shock, I think, to some of us to receive the communication. And are there ways that we can do this in the future that make it a little bit more collaborative, not taking away from the immense responsibility that you hold as the FDA to regulate?
Yeah, no, you're absolutely correct, Damien. It's always ideal when we can provide some pre-information to a lot of the stakeholders like SCAI, PICS, and others that may be able to start to think about this issue as it evolves. We certainly engage as much of a collaborative process as possible. We can continue to work on the collaborations with respect to communications like this. We do, and I'll say our Center for Drug Evaluation Research, who is the lead on this drug safety communication, certainly does take the initiative to engage with a lot of their community and clinical community partners, sometimes prior to putting out communications like this. It's not always ideal, and we can continue to improve on that. And again, truly appreciate the efforts from SCAI and PICS and others in helping with this.
Just, I suppose, one comment as well to finish with is that probably a huge and a bigger issue for us at the moment is the availability of contrast. I think it's starting to affect a lot of labs around the world because of contrast shortage. So something else that we might need to tackle soon enough.
And we're aware of that. Our teams are working on it. And I'll say for now that we're hopeful that the shortage should be adequately addressed and hopefully fully mitigated soon.
Thank you so much, guys. We have to cut this off, even though I know we can go for another hour just talking about this. I really appreciate Dr. Peiris' time and for all of your attention. We're going to follow this up with both collaborations with other societies as well as our own to internally put out the word on how our community feels. Thank you so much.
Thank you.